Okay, let's get right into it. We're looking at something kind of wild here. A medical breakthrough that people are calling a miracle cure, but it's also pushing the entire US healthcare system right to the edge. This is the story of how a solution to one massive crisis might just be creating another one.
So just how shaky was the system to begin with? Well, this number really says it all. A recent eHealth survey found that a whopping 72% of Americans give our healthcare system a C grade or worse. Think about that. Nearly 3 out of 4 people were already fed up before these new drugs even entered the picture. And that really tees up the central question, right? These new weight loss drugs are, no joke, a public health game changer. But their incredible success, smashed up against these sky-high price tags, is basically putting all the existing cracks in American healthcare under a giant magnifying glass.
To really get what's happening, we need to understand how the stage was set. Long before these drugs hit the scene, 2 huge, separate storms were already brewing. 1, a deep-seated public anger with the healthcare system, and 2, a full-blown national obesity epidemic.
So who were people blaming for this mess? Well, according to that same survey, it's not really doctors or hospitals. As you can see, 2/3 of people point the finger directly at insurance companies. And coming in at a close second, 60% blame the drug companies. This pre-existing distrust, it's a huge piece of the puzzle.
At the exact same time the public was fuming about costs, this other crisis was getting bigger and bigger. Obesity had become one of the most serious public health challenges this country has ever faced, and that created this massive latent demand for any new treatment that might actually work. And how big are we talking? Over 40% of adults in the US are living with obesity. Just let that sink in for a second. We are not talking about some rare condition. We're talking about a potential patient population of well over 100 million people. That scale is absolutely key to understanding the shockwave these new drugs are sending through the system.
So you have a deeply frustrated public and a massive health crisis. It's like a powder keg. And into this perfect storm comes the spark, a truly revolutionary class of drugs called GLP-1 receptor agonists.
So what exactly are these things? Well, to put it simply, GLP-1s copy a hormone our body naturally makes that, tells your brain you're full and helps manage your blood sugar. They were first made for diabetes, but their side effect, major weight loss, has been nothing short of a revolution. And this is why it's a revolution. Look at the options. For years, surgery was the best you could do, giving you 20–30% weight loss. Older pills? Maybe 5%. But these new GLP-1 drugs, they're delivering 10–15% weight loss. That's getting close to surgical results from a simple weekly shot. So yeah, it's no surprise the public demand has been completely off the charts.
And all that demand? It turned into a literal explosion in spending. A recent study in JAMA found that what we spend on these drugs in the US shot up from just under $14 billion in 2018 to nearly $72 billion in 2023. That is a 500% increase in just 5 years. Insane.
All that spending leads us right to the heart of the problem, the incredible price of these drugs and the super complicated kind of shadowy system that decides who pays what. Okay, so this is a really critical point. The difference between something being cost-effective and something being affordable. You gotta get this. A drug can be cost-effective over, say, 30 years because it prevents heart attacks or other expensive problems. But that does not mean a health plan can actually afford the huge upfront cost for millions of people all at once without going totally broke or jacking up everyone's premiums. Which, of course, leads to the billion-dollar question. If the list price isn't the real price and the long-term value is one thing, who is actually setting the prices that are health plans and we end up paying? The answer is, well, it's a mess. Now, don't let your eyes glaze over here. This chart from the Federal Trade Commission looks like a tangled web for a reason, because it is. You don't need to follow every little line. The main thing to see is that after years and years of mergers, the whole drug pricing system is basically run by a handful of giant, powerful middlemen who sit between the company that makes the drug and your local pharmacy.
And the most important middleman, the one you've probably never heard of, is the Pharmacy Benefit Manager, or PBM. Your insurance company hires them to do the negotiating with drug makers, to decide which drugs are covered, and to process your prescriptions. They are right in the center of this whole story.
And these PBMs are under some serious heat right now. A recent FTC report put it pretty bluntly, saying they may be profiting by inflating drug costs. So how on earth is that possible? It all comes down to this really complex system of rebates. The higher a drug's official list price, the bigger the rebate the PBM can negotiate. And this creates this totally backward incentive for them to actually prefer more expensive drugs, because a bigger rebate can mean a bigger payday for the PBM. It's weird. So what happens when you mix massive demand, these astronomical prices, and this really opaque middleman system? You get a perfect storm, and we're going to look at a real-world example of the damage it can do. Let's talk about North Carolina. Their health plan for state employees, which covers about 750,000 people, looked at the evidence and decided, hey, let's cover these drugs. They were trying to do the right thing for their people.
But then they hit a wall. According to the state officials, their PBM gave them an ultimatum. To get a big 40% discount, they had to cover every single person who was eligible, with zero restrictions. They couldn't, for example, just limit coverage to the sickest patients to control costs. It was all or nothing.
The guy running the plan, Sam Watts, he summed up the impossible situation perfectly. He basically felt trapped. He said of the PBMs, they are all or nothing. I've got to take it or leave it.
And you can probably guess what happened next. The state was staring down a potential billion-dollar budget gap and the possibility of having to double what employees pay for their insurance. So they made a really painful decision. They cut off all coverage for the new weight loss drugs entirely, leaving thousands of people high and dry.
That North Carolina story is basically a giant red flag for the whole country. It proves the way we're doing things now just isn't working. So the big question is, what happens now? How do we even begin to fix this? Well, it seems like there are three main paths people are looking at. First, just good old-fashioned competition. There are something like 16 new obesity drugs in the pipeline for the next few years, and the hope is that more options will naturally push prices down. Second, government negotiation. For the first time, Medicare can now negotiate prices directly, and it's already expected to save $6 billion on just 10 drugs in its first year. And third, more transparency. Regulators are finally shining a bright light on how PBMs do business, and that could lead to some major changes. So here's the thought I want to leave you with. This medical miracle didn't create the problems in our healthcare system, but its unbelievable success and its staggering cost have exposed the deep structural cracks for everyone to see. Honestly, inventing the drugs might have been the easy part. The real challenge, the thing that's going to define American healthcare for years to come, is whether we have the courage to actually fix the broken system that these drugs have laid bare.